Welcome, I'm Deepak Bhatt, reporting for ACC.org here in Barcelona at the European Society of Cardiology. And I'm lucky to be here with Dr. Fred Beauvais to discuss some of the really exciting trials that were just presented. Maybe we can start off with the EXFOR trial. That's probably the trial that could change clinical practice of the ones presented today. This was a trial in patients who needed elective cardioversion for atrial fibrillation, randomized to either rivaroxaban or warfarin. What did you think?
Well, you know, this is a big question that's coming up. We have more patients on NOACs, and the question is if they come up for cardioversion, can you use a NOAC pre-cardioversion compared to warfarin? We know about warfarin, don't know about NOACs. This was a trial that asked that question. And they compared rivaroxaban to warfarin. They had two groups, short time to cardioversion and delayed time to cardioversion. The short time was from randomization to cardioversion about 5 days, and delayed about 25 days or so. The delayed group required the first 30 days of therapeutic warfarin before they did the cardioversion. Rivaroxaban could have been used a little bit earlier, so they had an average of 25 days to cardioversion. The short group was 5 days, and both for warfarin and for rivaroxaban. It's not clear at this point how much heparin was used in that group, but fact is both had about the same outcome, very low complication rates in either case. And I think the message is you can use rivaroxaban. I think we could probably expand it to other NOACs as well, but you can use a NOAC pre-cardioversion without having to wait 30 days. I think it's pretty valuable information from the standpoint of managing patients with AFib.
Absolutely, and if you're going to wait for 3 weeks of therapeutic anticoagulation, of course, with a NOAC, you'll hit that sooner than having to wait for the warfarin to kick in, so potentially some practical advantages in terms of timing. Another interesting trial I thought was the STIX trial. This was a trial of statins perioperatively for elective cardiac surgery to see if they could reduce AFib and other complications. And of course, there have been observational studies, small randomized trials suggesting potentially large benefits, in particular on AFib. But what did the STIX trial show?
Yeah, rosuvastatin, 20 milligrams, starting just before surgery and going through and after bypass surgery or cardiac surgery. No difference in the AFib rates within the surgical post-op period, and no other benefits that were apparent. So there doesn't seem to be a benefit from the anti-inflammatory effect of a statin in improving the outcomes after cardiac surgery.
Though I think it does show once again that small studies, observational studies, even small randomized studies can provide an overestimate of benefit or just a totally false signal, as appears to be the case here. That's not to say that statins aren't important just in patients with atherosclerosis who might be undergoing CABG, but they don't have a specific anti-inflammatory benefit peri-op. Well, what about the AMIO-CAT trial? That was an interesting study, I thought, of patients who were getting AFib ablation, an increasingly common procedure for AFib, randomized to early AMIO or not.
Well, I think, first of all, patients go into AFib ablation thinking that they're going to be cured after the first procedure.
That's
and
right.
You know, we already know that probably about 35 or 40% of people are going to get a recurrence and need a second ablation. So the question is, could you reduce that recurrence rate by using amiodarone? So the study was a look at using amio at the time of ablation for 8 weeks post-ablation to see if they could reduce the recurrence rate. The first 3 months had a significant drop in recurrence rate, 34% in the amio group, 50-some% in the placebo group. So they were able to reduce hospitalizations in the first 3 months. The amio was for 8 weeks and it was stopped. At 6 months, however, the outcomes were about the same in terms of recurrence rate. You could argue that this is just a study that tells you that amiodarone reduces the risk for atrial fibrillation, because during that first 3 months, 8 weeks of that was active amniotherapy, and then there was probably a tail of another week or so with a little bit left over. So you could argue that using amiodarone in the first 3 months can reduce hospitalizations a little bit. One could argue that if you went longer than 8 weeks, you might be able to reduce the recurrence rate at 6 months, but they didn't ask that question.
Sure, although in a sense then you're kind of right back where you started from, right? Because you're still on an antiarrhythmic, so if the goal was to not be on an antiarrhythmic, then the AFib ablation may not have done everything it was intended to do, I suppose. But I think that is another key, though confirmatory observation, that the AFib recurrence rates were kind of high after an AFib ablation. So probably a lot of work that still needs to be done with AFib ablation to try to make it a more durable procedure.
I think so. I mean, as I said, I think patients kind of get the idea that they're going to be done after one procedure, and I think it's fair to be honest with the patients that there's a pretty good chance that they're going to come back once in a year to get a second ablation if they want to get a reasonable outcome at the end of it all.
Right. One final trial that I think is worth mentioning that has, I believe, some relevance even in other parts of the world was a study done in Africa, and this was examining patients with tuberculous pericarditis, something that we may not see a lot of in the U.S., though you perhaps see a bit more of it than I do. Where they studied steroids to see what effect they may have. And
yeah.
What do you think of that
study?
Well,
it talks a little bit about the healthcare in Africa. I mean, this is 2/3 of the patients with HIV/AIDS, so we already know that they're at high risk for tuberculosis. You'll find similar types of problems coming up in inner cities where there's a higher incidence of
right.
HIV as well. They asked the question of whether prednisolone would improve outcome with after the diagnosis of tuberculous pericarditis, and they had a vaccine which was made up of a similar bacteria that they were using as a comparator. The message was that, number one, the vaccine didn't work and actually increased the risk of cancer at 3 years with the HIV patients. 2/3 of the patients had HIV. One of the sad things is only 14% of them were on antiretroviral therapy.
Right.
But the prednisolone did reduce the recurrence, actually the rate of constrictive pericarditis, which is always a problem in TB pericarditis. So there was some benefit of prednisolone in the first 90 days with a taper, and the vaccine didn't work, but talks about the health problems we see in the HIV population.
Well, I would really congratulate the investigators in Africa for stepping up to the plate and doing a really challenging trial and providing very clinically useful information. Well, those were some of the exciting trials that we got to hear today at ESC. Hopefully that's useful to you back home.